The topic that we selected to talk about today was IVIg, plasma exchange, and new therapies. This is definitely a area of a lot of discussion with our patients. It's interesting because this is a group that's very knowledgeable about MG, and I would bet that maybe a majority of the audience has received one of those treatments for some amount of time or currently in the past, because they're not used that rarely. So hopefully our talk is at the appropriate level even for those of you who come in with a lot of knowledge about these things. And then we're also going to mention some new therapies that are, I would say, emerging because they're things that are out there but not necessarily used as often right now. So everybody here knows what myasthenia gravis is. I think it's important to review this a little bit as we get into these treatments. So MG is an autoimmune disorder that affects the neuromuscular junction. So when it comes down to it, it's an autoimmune problem that's going to end up blocking the communication between the nerves and the muscles. And the hallmark feature is always muscle weakness of some type. And as you know, this could prominently be weakness of the eyes or the eyelids. It could be in the arms and legs. It could be affecting what we call the bulbar muscles, which are those of speaking and swallowing. And the pattern can be highly variable depending upon who the patient is. And most often, people, if you test their blood, have acetylcholine receptor antibodies. So the majority of people with myasthenia gravis will come back acetylcholine receptor antibody positive, but not everybody. Some people will possess a different antibody, especially the MuSK antibody that Joan mentioned earlier, and we're going to come back to that in a few minutes. And also some other antibodies which we're just discovering now. But despite all of that, some people, we never find the causative antibody on their blood tests. This is a picture of what the neuromuscular junction looks like. And it's simply the spot where the nerve meets the muscle, but they're not physically touching. And in order to communicate with one another, they rely on chemistry and sending us across the chemical acetylcholine. When the acetylcholine is released from the nerve, travels across and binds to the muscle, that tells the muscle that it's time to contract. So any interference in that communication process is going to result in muscle weakness. In myasthenia gravis, there are antibodies that are glopping onto or damaging the acetylcholine receptors, so they don't function as well. When the acetylcholine travels across and tries to communicate with the muscle, they are no longer able to sense that stimulus and they don't contract as well. And that is why people end up with muscle weakness. Before we delve into talking about treatments, I'm going to answer questions at the end. There are some blue or yellow note cards at your tables, it looks like, that you can write your questions on. And then at the end, you can just hold those up and I'll swoop around and get them, and then we'll answer as many of them as we can. And you can ask whatever you'd like. Joan did send me a couple of questions ahead of time. I have them in my phone, so I'll pull those out as well. So what does the treatment of myasthenia gravis consist of? A few different things. And there are many different treatments that a patient might be faced with depending upon how severe their symptoms are and how aggressive they and their doctor want to be. The first thing that folks often hear about is pyridostigmine or mestinon. And this one is what I would call purely a symptomatic treatment. And this acts to inhibit what's called acetylcholinesterase enzyme. So if somebody is taking this chemical, their body is not going to break down as much of their acetylcholine chemical. So there's going to be more of it floating around and available to bind to the muscles. In other words, we're trying to outcompete the myasthenia gravis. The muscles are having trouble communicating, so we're just trying to get around that by giving somebody more acetylcholine. But that's purely a symptomatic treatment. It can make somebody feel better, but it's not really addressing the underlying autoimmune problem. So nobody can go into a remission based off of receiving pyridostigmine because it's only treating the symptoms. It's not treating the autoimmune problem. Now, we should always let the punishment fit the crime. And if somebody only has very mild symptoms, that might be all that they need to get by. And in fact, they might only take it once or twice a week or once or twice a month, and that can be okay too. But if somebody's symptoms are more severe or more bothersome or more disabling, they're probably going to need something that addresses the immune system. The first immune treatment that most people are faced with is prednisone or steroids or corticosteroids. And those words are all used interchangeably. And steroids obviously have many different effects on the body and its metabolism. But when we give steroids for myasthenia gravis, we're not trying to roid them up or make them stronger. We're actually trying to address the autoimmune response. And the steroids have effects to decrease the function of our immune system a little bit. And that can be one of our most effective treatments for myasthenia gravis. And in a lot of people, that might be the only immune treatment that they need. But it gets more complicated from there for a few reasons. Number one, as you know, steroids have a ton of side effects. And the longer you're on them, the more side effects you can get. And the more we worry less about small side effects like difficulty sleeping, and more about big side effects like diabetes, broken bones, things like that. So the side effect profile isn't good. Second, sometimes people have very severe weakness, and that weakness either doesn't respond to the steroids, or they have very severe weakness that's almost an emergency, and we need something that's going to work even faster. And that's where we get into the next category that I refer to as rescue therapies. And these are classically IVIg and plasma exchange or plasmapheresis. And we're going to spend quite a bit of time talking about those two things. The next category is referred to as steroid-sparing agents. And these are medications that also address the immune system. And the goal is for them to replace prednisone in somebody who's on prednisone. So we talked about those worrisome long-term side effects of prednisone. And sometimes you want to continue the effect on the immune system, but get somebody off of prednisone. And in that situation, we might start one of these steroid-sparing agents. And once somebody's been on that for a while, you can taper off the prednisone with more ease and more success. The issue with these medications is that one of the big issues is that they take a really long time to work, usually a period of months, many months, which is a little bit weird as far as medications go, because it's the kind of thing that you need to think about whether or not someone's going to need it or want to be on it before they really need it. And these things can also have some side effects and can decrease the activity of the immune system a little bit. These are the types of medications that people are often on if they have other autoimmune conditions, like maybe lupus, or if they've had a transplant, like a kidney transplant. These are the same medications that are used to prevent rejection of somebody else's kidney. What about newer things that have come into existence over the past few years? So Rituximab is one of those things. And rituximab has really been around for a long time. We'll talk about it again in a little bit. And sometimes it's used as a rescue therapy. Sometimes we think of it more as a maintenance therapy. And then just FDA approved about a year and a half ago is Eculizumab, which the brand name of that is Solaris. And that is also a maintenance treatment for people with severe symptoms. And we're going to talk about that a little later as well. So a few confusing points I find in myasthenia gravis when we're teaching residents and fellows and students about this condition, and you probably experience some of the same confusion, is some of the terms that we use. For example, myasthenic crisis or exacerbation or flare. Sometimes those words are used sort of interchangeably. I consider myasthenic crisis to be when somebody's symptoms have worsened fairly abruptly and their breathing is involved. A flare or an exacerbation is when somebody's symptoms have been getting worse to the point that they're very severe. But in myasthenia gravis, we also have a lot of people with what I consider just bad symptoms. And maybe they've had really severe symptoms that are disabling for many weeks or many months or years. And we see that sometimes too. And I don't know if you would call that an exacerbation or a flare, and it's probably not a crisis, but there's certainly people who need more aggressive treatment. And another confusing point is rescue therapy versus maintenance therapy. And this is where some of the finer points of the treatments of myasthenia gravis come in. Because most often, things like IVIg and plasma exchange are used as rescue therapies. Somebody is getting worse, they call the doctor, they say go to the emergency room or something, they get admitted and they get one of these treatments and they go home. But not infrequently, we have people who have severe symptoms and persistent problems, and they're actually going to receive one of those aggressive treatments on a consistent basis as a maintenance treatment. So yes, you hear about IVIg and plasma exchange as rescue treatments a lot, but they have some utility as maintenance treatments as well in people who are severely affected. So what about steroids? I think I already made some of these points. Steroids are a really good treatment for myasthenia gravis. We all know that, but if you give somebody an abrupt dose of very high steroids, it can actually make them worse temporarily. It can precipitate a small worsening in their breathing that can get them into trouble, which is why high-dose steroids are often not the treatment that we use for somebody in a true myasthenic crisis. So we need better rescue therapies than just steroids. And then chronic dosing of steroids leads to many different side effects. So we need alternatives. So this is where IVIg and plasma exchange come in. So for each of these treatments, I'm going to talk a little bit about what it is, what are its uses, how is it given, and what's the experience like of getting it, and then what are the potential side effects to think about or worry about. So we'll start with IVIg, and I bet a lot of people in this room have received IVIg or are receiving it. So IVIg is a blood product, and it doesn't look like a bag of blood because it is antibodies that have been obtained from many hundreds or thousands of blood donors. So it's just antibody-rich liquid without other components of the blood. So you're receiving an infusion of other people's antibodies. And it's a collection of all the antibodies in the blood. They could be antibodies against different viruses or bacteria. We don't know. It's all of them. And the mechanism of action for autoimmune diseases like myasthenia gravis is not really straightforward. It binds to our white blood cells, the main cells of the immune system, and it prevents them from participating in unwanted autoimmune responses. So I tend to think of it as distracting the immune system. We're giving your body a set of antibodies, and it's binding to your own white blood cells, and then your white blood cells aren't free to do the damage that they have been doing. And IVIg is used for a number of different autoimmune conditions. It's also used for people who don't have enough immune system. So there are immunodeficiency syndromes, and usually people are born with those. And in that case, we replace the antibodies with other people's antibodies, but we also use it for autoimmune conditions. We talk about the dose of IVIg in grams or grams per kilogram, which is one reason why we probably weigh you when you come to the doctor. And the first time somebody receives IVIg, or if they're receiving it for a crisis or an exacerbation, they usually get a double dose, which we'll sometimes refer to as a loading dose, which is 2 grams per kilogram often. So if you're the average 70 kilogram man, you would get 140 grams in your load. And then a maintenance dose, if they're going to be continued, is often 1 gram per kilogram. So, you know, for the average adult, usually somewhere between 50 and 100 grams. Those doses can be divided up over 1 to 5 days. So if somebody comes to the hospital and they're in a myasthenic crisis and they need to get admitted and get this loading dose of IVIg, sometimes we give it over just 2 days. Sometimes that person is getting it divided up over 5 days. Medically, it probably doesn't matter too much. If you give less of the IVIg on a given day, there's probably going to be fewer side effects, but you're committing that person to more days of treatment. So sometimes if somebody's really sick and maybe they also have an infection and they're going to need rehab, I'll give them the treatment over 5 days because they're going to be our guest in the hospital anyways. But if somebody's otherwise healthy and wants to get back to work or something like that, it can often be given over fewer days. For maintenance treatment, somebody is going to get their treatment once every X number of weeks. So somebody might get a booster dose of IVIg every 4 weeks, every 3 weeks, every 2 weeks, sometimes every 5, 6, or even 8 weeks. IVIg probably lasts in your blood for close to 4 weeks. Some people do need the dose up more frequently than that to keep distracting the immune system as much as we want. An interesting point is that there are many different brands of IVIg, and sometimes these are advertised to patients, sometimes that they're advertised to doctors. My personal take on this is that I care more about getting the person what they need when they need it than the exact brand. In years past, before I was in practice, there was probably more difference across the brands. Some of them were probably higher in protein content and things like that, and would have more side effects or more risk for side effects. These days, they're mostly all pretty safe. So we often give people what's available, or we allow substitution by the pharmacy. So this one, for example, GammaGuard, is a very commonly used product. It's been on shortage a lot in the last 6 months or so. So other products have been used more often, but it probably doesn't matter too much. There's also differences in concentration of how much antibodies there is per amount of liquid, which can be another difference across the products. Another confusing point is something called IgA. And all of us produce antibodies, and there are a few different types of antibodies that serve different purposes. And these are different proteins that circulate in the blood to attack infection. There is one type of antibody called IgA, and for whatever reason, some people are born deficient in this. If you give somebody who does not have their own IgA, somebody else's IgA in the form of IVIg, they can actually have an allergic response to it. So prior to starting IVIg, some specialists will check a patient's IgA level to make sure they're not deficient. Now, there's some caveats there because, one, IgA deficiency, being one of these people who could be allergic to the IgA, is actually really rare. And second, most of the modern IVIg products are depletes of IgA. There's not a lot of that in there. So if somebody is just walking in and they have myasthenia gravis, it usually is safe to just give them IVIg without checking the IgA level. With the luxury of time, we often do check that level to see. And then if somebody did have IgA deficiency, we would know to give them one of the products that does not have any IgA in it. So the uses of IVIg are often as a rescue therapy, which is a larger dose given over 2 to 5 days often, or as a maintenance treatment, often every 2 to 8 weeks. IVIg, you might guess based on the name, is given through a vein. It's an IV treatment. So this is infused into somebody's vein, and that infusion of the product typically lasts for several hours. And it can be quite a time commitment. And there's a nurse who is watching your vital signs very frequently. Because it's a bag of immune stuff, people can have changes in their heart rate or flushing pretty commonly. So they check your blood pressure very frequently and keep a close eye on you. But the infusions tend to last several hours. If somebody is receiving maintenance treatments, oftentimes the nurse will start gradually speeding it up on subsequent treatments to see how someone can do. The benefits of an infusion may not be seen for several days. So it's not immediate as the treatment is going in that somebody feels better. It's often 2, 3, 4, 5 days down the road that somebody is going to feel the boost. In fact, the day of and the day after the treatment, a lot of people feel worn out, they feel fatigued, they feel extra tired, extra weak for the day of. That's pretty common. And there's a few reasons for that. One is just the ordeal of the treatment. Another one is probably its effects on the body. And then often people are given Benadryl along with it to prevent allergies, which can be very sedating. The benefit tends to last some number of weeks, and then many folks will notice a wearing off effect before the next dose is due. In other words, they'll start noticing that they're beginning to feel their symptoms come back prior to the next dose. What are the potential side effects of IVIg to be aware of? There can be many. In general, it's something that is very safe. The majority of people getting these treatments don't have severe side effects or toxicities, but side effects are not uncommon either. So one of the most common side effects can be a headache. And that headache can begin with or immediately after the infusion, and it can be very severe. In its most severe form, that headache can look just like somebody with meningitis. The ways to prevent the headache would be running the infusion slower, sometimes giving somebody a dose of steroid with the infusion, and then staying extra well hydrated around the time of the infusion can be helpful too. Drinking Gatorade the day before and the day of, sometimes getting IV fluid with the treatment. People can have hives or a rash along with IVIg. Sometimes that happens with every dose. Sometimes it's just a product of whatever antibody they got with that treatment, triggered their immune system a little bit. They can have fevers. A potentially worrisome complication would be any type of blood clotting. So IVIg is very protein rich because it's made up of antibodies, so it's going to make the blood a little bit thicker. If somebody is already prone to blood clotting, or they already have very narrow blood vessels because they have heart disease, it could contribute to them having a heart attack or a stroke. Those events are very rare, thankfully, but it can happen. So we want to think about the person's overall medical problems. For the same reasons, because it's a lot of protein, we can sometimes see people with kidney or renal injury. Lastly, I would mention that when somebody gets IVIg, it's a lot of fluid that we're running into them through the veins. So if somebody is sensitive to swelling or has mild heart failure, they can either swell, or if they already have heart failure, it could worsen their heart failure. So we also want to be careful in people with heart problems. Speaking of newer treatments, something that you will be hearing more about in coming years is subcutaneous immune globulin. Sometimes I accidentally call this subcutaneous IVIg, but it's really not IV anymore. It's subcutaneous immune globulin. And this is putting antibodies not into the vein, but under the skin. And there are a couple potential advantages of that. One is that you don't need a nurse to start an IV. And patients can do this on their own if they're comfortable doing so, sticking a very thin needle under the skin. And two is that it can have fewer side effects potentially. Because that immune globulin is going to be absorbed very slowly into the rest of the body, people can be less prone to headache, and they can be less prone to severe side effects like kidney injury as well. What are the issues with this treatment? So the person doing it has to be comfortable doing it. If you're squeamish about giving yourself shots, it probably wouldn't be a great idea. It's a lot of fluid to put under the skin, and it often has to be done every week. So, as opposed to a couple days ago, I had to do a TB test for work, and it's just like a little bubble of fluid. This is like 10 times that amount. And in order to get the adequate amount of immune globulin, it often has to be weekly. The trade-off of that is you're not going to an infusion center, a nurse isn't coming to your house, they're just shipping the stuff to your house. The big hurdle to doing this at this point is cost. And while it on face value isn't really that much more expensive than IVIg, it's not FDA approved for myasthenia gravis right now. So it does not get approved by insurance easily. There are other similar conditions where it is FDA approved, Especially, there's something called CIDP, which is an autoimmune nerve problem that we also treat a lot of. And for that condition, it is approved by the Food and Drug Administration. So I think that that's coming. Right now, I have one patient getting subcutaneous Ig for myasthenia gravis, but she actually just got the first dose yesterday. So I can't tell you how she's doing quite yet, but this is probably something that we'll see more of in the future. So next, we're going to move on to talking about plasma exchange a little bit, and we'll have another discussion of that coming up in a few minutes. Plasma exchange can be a little bit confusing in its word choice. Plasma exchange and plasmapheresis are pretty much used interchangeably by doctors or neuromuscular specialists. I think from the blood bank standpoint, there might be some small differences there, but we toss around those words interchangeably. Sometimes we call it PLEX for short. Sometimes we call it apheresis as well. But they are all equivalent procedures. This is a dialysis-like procedure that's performed on the veins. And somebody is hooked up to a machine that takes blood out and puts blood back in. And the goal is to effectively skim the blood of harmful antibodies to remove them so that they're no longer able to cause destruction to the muscles and drive somebody's weakness. This is often used as a rescue therapy for people who are in a state of crisis or severe exacerbation. And in that situation, people tend to get several sessions over the course of 1 to 2 weeks. So often people are admitted to the hospital for maybe the period of 10 to 14 days, and you get a session of plasma exchange every other day on average, so that you're there for sometimes quite a few days. And for that reason, this is something that is often done on inpatients. Sometimes occasional sessions are helpful for somebody with worsening symptoms. Maybe somebody did really well with this in the hospital. They went home and they're still doing okay, but gradually backsliding a little bit, in which case you could try 1 session or 2 sessions as an outpatient to see if it gives them a boost. And sometimes this is used as a long-term maintenance treatment in a manner similar to IVIg. Somebody can be on plasma exchange every 2 weeks, every 3 weeks to get 1 session and maintain how well they're doing. In order to perform plasma exchange, the nurses who do the procedure need good access to somebody's veins. Sometimes really good nurses can just put large IVs into different veins, but that really depends on the hospital that you're at. Where I trained at the University of Michigan, if somebody was admitted to the hospital and they had just been diagnosed with myasthenia gravis, the apheresis nurse would come and meet them and look at their veins to see if they had big enough veins to get plasma exchange through their veins. But oftentimes somebody's veins are small, or they have aged, or at a lot of centers they don't do plasma exchange through somebody's own veins. You need some sort of other venous access. Most commonly, that's in the setting of a large temporary IV in the neck or chest area, referred to as a central line. And those large plastic IVs are often placed by a radiologist in a hospital so that they can look with X-ray guidance and ultrasound guidance to put the IV where it needs to go. In patients who are going to get plasma exchange on a more consistent basis, as an outpatient, usually other things are required. So rarely a myasthenia gravis patient might have a fistula placed, which is an artificial connection between the veins and arteries to create an area of increased blood flow that's easily accessed. That's fairly seldom done, and it's pretty invasive, but you will encounter that sometimes. And then on the market in the past few years, there are various types of ports that can be more permanently placed under the skin that they can access for plasma exchange. So if a family member or a friend or you have ever had a cancer that requires frequent chemotherapy, they often put in a port, which is like a button under the skin to make sure that it's always possible to get an IV if needed. And a specialized type of port can be placed for people who are going to get plasma exchange. Sometimes, if somebody is getting a lot of IVIg and they need frequent IV access, that person might get a port as well. Other times, somebody has just had so many different tests and treatments that their veins aren't as strong as they were, and that person might require a port as well. But it generally takes a specialized type of port to be able to do plasma exchange through it, but such a thing is out there. We've already talked about these points, that plasma exchange more often is done on hospital inpatients in our practice, and somebody needs to have good IV access, and often that person is going to be in the hospital for a 10 to 14 day hospital stay. So what are the potential problems or complications of plasma exchange? In general, it's very safe. And in fact, if somebody is very ill in the hospital and they have low blood pressure and they have an infection and pneumonia and all sorts of things going on, it can be especially safe in that person. And people tend to do really well with it. But some things to be aware of that your doctor will be watching for would be complications of having the large IV placed, bleeding in that area, for example. If somebody is undergoing plasma exchange, they're not only removing harmful antibodies, they're removing a few other proteins as well that can be helpful. Some of those proteins are useful for blood clotting. So people may be more prone to bleeding than they were previously. If somebody's admitted to the hospital, sometimes they follow certain blood clotting parameters every other day to make sure they're not getting too low. And then because you are removing some antibodies, people can be at somewhat higher risk of infection than they were before. But in general, it's very safe, very well tolerated. Is there medical evidence to support using either IVIg or plasma exchange? I'm confident that these things work, but we don't have as much evidence as we would like sometimes. So there is a randomized controlled trial that shows that IVIg is useful for patients with worsening weakness compared to a placebo after 2 days, after 2 weeks, or 4 weeks. In somebody with a myasthenic exacerbation or flare, there's evidence that IVIg and plasma exchange are useful for exacerbations, and they're probably equally effective. And there is evidence that if somebody is going to undergo a thymectomy surgery, if you underwent plasma exchange prior to your surgery, people tended to be in the ICU for less time and spend less time on a ventilator. Different talk for a different day, but the surgeons are getting better and better at thymus surgeries, and a lot of people aren't in an ICU or on a ventilator for very long any longer. What we don't really have great evidence for is the maintenance use of these treatments over many weeks or months or years. And sometimes that's how we're employing them. And I have had insurance companies come back and say, well, there's not medical evidence to support the maintenance use of IVIg for myasthenia gravis. I think that we know it works. I think that it is very effective. But I have seen that come up occasionally. So in review of what we've talked about so far, comparing IVIg and plasma exchange, IVIg is infused through veins, whereas plasma exchange is performed on veins. IVIg is infusing normal antibodies, whereas plasma exchange is filtering antibodies from blood. Both of them are a big time commitment. So an infusion of IVIg takes several hours, and a session of plasma exchange typically takes a couple of hours as well. The side effects of IVIg to be aware of, headache is probably the most common one to be aware of, but various allergies, flushing, rash are all possible. Different forms of blood clotting and kidney injury are other things that we have concern about as well. Plasma exchange, generally very safe, but the IV line and any complications of it, and also increased risk of bleeding and increased risk of infection potentially. The advantages of each of these things, for IVIg, it can often be started very quickly in somebody who's sick. So somebody can come to the emergency room and we can decide to give them IVIg, and if there's a pharmacist available, they can get the drug ready at the correct concentration, and the patient can be getting the treatment within a few hours. Plasma exchange can require a bit more of a time commitment, requires the IV line to be placed, and it requires a special nurse to run the machine. For IVIg, an effective loading dose could be given in 2 days, whereas a full course of plasma exchange often takes several days. And another advantage of IVIg is the feasibility to continue outpatient infusions. Can be done, and the person getting the treatments knows what it's going to be like. And it's just sometimes not as invasive. Advantages of plasma exchange can include that it can be done in very medically complex patients. It can be helpful immediately prior to thymus surgery. And plasma exchange is classically more effective for people with the MuSK type of antibodies. So if somebody has the MuSK antibodies, plasma exchange tends to be very helpful. IVIg is sometimes not very helpful. And then another advantage of plasma exchange is that it has a very clear and direct mechanism, and it can be very satisfying to think that you're removing the antibodies that are causing somebody's disease. Disadvantages of IVIg include the cost. It's expensive. Outpatient treatment often requires insurance approval, which can be a process. Severe complications of IVIg are pretty rare, but side effects are pretty common, and a lot of people deal with those quite a bit. And then serious complications are possible but rare. Plasma exchange often requires a hospital admission, unless we've taken special steps for somebody. The first time they get plasma exchange, it often requires a hospital admission. And it takes a lot of time. And special IV access often needs to be obtained. So that is IVIg and plasma exchange. I'm going to talk about a few other treatments that I would guess a lot of people in the room already know about, which are Rituximab and Eculizumab. So Rituximab is an antibody that a pharmaceutical company made to bind to a certain marker on white blood cells called CD20. And this stuff has been used for a long time, maybe 20 years, for different types of lymphoma, and also other autoimmune diseases like lupus or vasculitis. But it's been used with some regularity in myasthenia gravis also. Both acetylcholine receptor antibody positive myasthenia gravis and people with the MuSK antibodies. But there's not great quality of evidence to support its use. My own experience with this medication has been mixed. Some people have gotten really a lot better, dramatically better. Other people, it was like they got a type of placebo almost, and you just don't always know going in. So this is one of the more frequently cited articles that we have about this, about rituximab treatments, reviewing all the previous trials of using rituximab for myasthenia gravis. And the factors that tended to predict whether or not somebody was going to get better were having the MuSK type of antibody, being younger, and sometimes having milder symptoms to begin with. And there are studies that show that the antibody titers of myasthenia gravis, the amount of the antibody in your blood, tends to go down after getting rituximab. In general, again, it's a talk for a different day, the antibody testing is really a diagnostic test for myasthenia gravis. If it's positive, it's MG. If it's negative, we keep looking. But there are situations in which we follow somebody's antibody level and it can be of interest. There are a few different ways of giving somebody rituximab. So it's always given through the IV. Typically, if somebody is going to receive this treatment, it's often done in an infusion center or an infusion room or even an infusion center of a cancer center or something like that, although it can be done on inpatients as well sometimes. And there are a couple different schedules of giving it. If I'm going to give this, it's often given somebody, you give them a dose on day 1, and then you give them a second dose 2 weeks later. And then that's it for a period of 6 months. And then they can get another booster dose after 6 months. Other times, somebody gets a weekly dose for a month or so, for 4 weekly doses, and then no treatments for, again, several months. Prior to getting rituximab, most doctors will check different blood tests, like a TB test or hepatitis testing, because if somebody is harboring one of those infections without symptoms of it, and you get this treatment, those infections could flare up. But generally, it is pretty safe and well tolerated. What about Eculizumab? So the brand name for Eculizumab is Solaris. It's been around for a little over a year now. And this medication is interesting to me because it works in a different way. And it works on a series of proteins which is called complement. And complement is not just a nice thing you'd say to somebody. It's also a set of proteins that the body uses to label cells for inflammation. And in myasthenia gravis, this system of proteins has been activated by the person's autoimmune response. So if we interfere with it, we can decrease the activity of the myasthenia gravis. So Eculizumab is an antibody that a pharmaceutical company developed against one of the proteins of complement. This This medication has been around for several years, but really used for very, very, very rare hematology disorders called paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome, which are both so rare that they would make MG look like the flu. So they were interested in finding other applications for this drug. And it was studied in a randomized controlled trial across 76 different hospitals in many different countries. And to get into this trial, MG patients had to have an MGAFA class of 2 to 4. We'll look at exactly what that means in a second. And an MG-ADL score of 6 or more. And they also had to have previous treatment with failure with at least 2 immunosuppressive therapies in the last 12 months. And that really applies to a lot of people with myasthenia gravis. If you've been on prednisone and azathioprine, if you've been on prednisone and had IVIg a couple of times, if you had a hospital admission for plasma exchange and you're on mycophenolate and you're still not doing well, you would fall into this category. The primary endpoint of the study was the change in the MG-ADL score. So when they design clinical trials for medications, the primary endpoint is the measure that they're going to ask patients about and that then they're going to run their statistics on to see whether or not the drug had a meaningful impact. So the MGFA class is a way of sorting out how severe somebody's myasthenia gravis symptoms are. So class 1 is only ocular muscle weakness or droopy eyelids. Now, those of us in this room know that you can have just ocular symptoms of MG and it can still be disabling. But class 1 is only ocular findings. And then class 5 is breathing symptoms so severe that somebody is on a ventilator. So this treatment trial was for anybody with generalized myasthenia gravis. Anybody with symptoms that don't just affect the eyes, but anybody who is mobile enough to come to a doctor's appointment. And then the MG-ADL score is a composite of different measures or questions that your doctor probably already asks. Are you having difficulty chewing? Do you have difficulty getting out of a chair? How often do you have double vision? Things like that. And then you tally up those points to give somebody a score. So here's where this got a little bit weird. They enrolled 170 patients, and 63 got placebo, 63 got the medication. So you remember that they were doing this at 76 different hospitals. So it shows how hard it is to really study myasthenia gravis because they needed to get 76 different researchers to participate in order to find 126 patients to enroll in the treatment. So it takes a lot of time to find people who qualify. And then these charts on the right, they're going to be too small to see. But their primary endpoint was this thing called the MG-ADL score, and the blue line is the people who got the medication. The red line is people who are actually getting placebo. So even the people who were getting placebo felt a little bit better due to the placebo effect, but the people getting the medication felt better. When they ran statistics on this, the difference was not very significant. There was a lot of overlap between the two groups. But there was enough of a difference that the Food and Drug Administration gave the drug approval. And it was the first medication to get FDA approval for maintenance treatment of myasthenia gravis in decades. Part of the reason it got a lot of approval is if you go into some of the secondary information, it did a lot of really good things. So admissions to the hospital were half in the Eculizumab group compared to the placebo group, which was really good. So it is approved, and we are using this. And at Rush right now, we have about 6 or 7 patients getting Eculizumab. And everybody who's getting it has gotten better to some extent. It's not a miracle over other treatments that we have available, but it is another option, and it works differently. So it can help some people who are in a tough spot. One of the issues with this medicine is that it requires fairly frequent treatment. So for the first month, you get a weekly infusion at a lower dose. And then after that month, you get 1 dose every other week. And then you continue on the drug every other week. I'll get to this in a minute, but the most common or worrisome side effect of this medication is based on the way it interacts with the immune system. It can leave people vulnerable to meningitis, the bad kind of meningitis that you hear about college kids getting. So before getting the treatment, patients need to get the meningitis vaccine. And there's actually 2 different meningitis vaccines that you get. And you need to have those 2 weeks before starting the treatment, and then a booster dose after 6 months. We're new to this medication, and it's still not clear how effective the vaccination is if you're on this powerful medication. So I advise my people getting this medication to be very vigilant if you have a fever, if you have a headache, if you're feeling sick. You need to have a low threshold for calling us or your primary care doctor or going to an urgent care or something like that. So key points for the Rituximab, it's often given weekly for a month or 2 doses 2 weeks apart, then repeated several months later. The advantages is some people it can help quite dramatically, almost to the point of a remission. Fairly few infusions are needed, and there's fairly few side effects. The disadvantages are it's not effective for everyone, it's very expensive, and there's some risk of opportunistic infection to be aware of. Eculizumab or Soliris is weekly for a month, then every other week after that. If you've ever received IVIg, you know that one thing that we often do with that medication is gradually space it out or taper it out until hopefully somebody is off of it. In this trial of the new medication Soliris, they just kept giving people the treatment every other week and every other week and every other week and every other week, and they kept doing well. But we don't know what happens to those people when the drug is stopped. Presumably, their symptoms would just come back. I do have one person who was doing really well on Soliris, so we're starting to space it out, and she's still doing well. But if we're thinking about this medication because somebody is requiring IVIg infusions every 2 or 3 weeks, it doesn't really buy you less infusion treatments because you are forced into taking infusions fairly frequently. The advantages are that it's often effective, it has a different mechanism. We're doing home infusions of Soliris. There are fairly few day-to-day side effects, although several different side effects are possible. The disadvantages are the cost, meningitis concerns, frequency of infusions, the unclear tapering plan. In the folks in whom we've done Soliris, their insurance has approved it. I assume these are people, their insurance company probably knows them by name because they've been getting a lot of different treatments. over a long amount of time, and the goal is to keep somebody out of the hospital, maintain their overall health, and it is FDA approved. So insurance approval typically is possible in somebody who's a candidate. So that's all I had prepared for today.